A 50 years old female represent in the hand clinic with a generalized swelling of the arm. The swelling was previously even more prominent. She reports a constant burning pain. This all started a couple of weeks back when she had an MRI and an IV access was started in the right antecubital fossa. The gadolinium was used as a contrast medium. Since then, she had an arm and the forearm swelling, which did reduce in size with the passage of time, but she still reports numbness, cyanosis, and burning pain. She reports some changes in the coloration of the hand and pain while moving her wrist and elbow, and even part of the shoulder movements are painful. What is it? The differential here can be multiple, but the diagnosis is complex regional pain syndrome or reflex sympathetic dystrophy. It's a non-specific diagnosis. There are no radiological findings specific for it. The radiological findings can be of result of prolonged disuse, which is attributed to the pain associated with the syndrome. However, imaging studies can support a diagnosis of complex regional pain syndrome or CPRS. Radiography may help to suggest the presence of CPRS. Early radiological changes seen with sympathetic hyperdysfunction include patchy demineralization of the epiphysis and short bones of the hand and the feet. Periarticular osteoporosis in the long bones and disuse osteoporosis in the small bones is seen on radiograph. There may be subperiosteal resorption, striations, and tunneling of the cortex. Comparison with the opposite limb is always required. Unfortunately, these findings are also present in disuse of the limb, and patchy osteopenia continues to increase. A triple bone scan is often leads to diagnosis. A three-phase bone scanning measures the uptake of nucleotide tracer at three different time intervals. One is arterial phase, measures seconds after the injection of the tracer. Then is a soft tissue phase, measured after several minutes have passed, and a mineral phase or a bone phase, measured hours after tracer is given up. The triple bone scan more consistent with CPRS is that of increased flow in the involved extremity and delayed static imaging that show diffuse intake activity throughout the involved extremity, including a more periarticular distribution. MRI studies may show skin thickening and tissue edema. Regarding the differentials in scenario, it can be different. The differential diagnosis can be peripheral neuropathy, inflammatory disease, infectious disease, vascular disease, connective tissue disorders, and RSD itself. It's mostly a diagnosis of exclusion. Other causes of similar pain symptoms such as neuropathy, which may be present with neuropathic pain, traumatic injury to the nerve, may cause dysesthesia and paresthesias, which can be one of the differential. Inflammatory and infectious causes for pain needs to be ruled out when autonomic dysfunction is the primary presenting symptom. Example of this can be tenosynovitis or bursitis. Vasculitis and vascular problems can be manifesting similar findings. In many instances, vascular disease represents itself in bilateral symptoms. Raynaud disease produces vasospasm that will lead to finding of pallor, color change, and potential cyanosis. Moreover, psychiatric disorders can be one of the differential diagnoses. The International Association for the Study of Pain, IASP, has renamed RSD as Complex Regional Pain Syndrome Type 1. This will aid in the development of treatment protocol for the syndromes. Previously, many symptoms constellations were included in the category of RSD, making treatment pathways and outcome studies difficult. To meet a criteria of CPRS type 1, a patient must be present with regional pain out of the distribution of a single peripheral nerve or out of proportion to the inciting event. CPRS has been reported to develop from compression, crush injuries, lacerations, fractures, sprains, burns, or surgery. Allodynia and hyperalgesia are typical present. Abnormality in skin blood flow, causing changes in the skin temperature and color. Abnormal pseudomotor activity and edema are also present. Dystonia and weakness, although not necessary for the diagnosis, may be present. Trophic changes and personality changes may develop with the passage of time. CPRS type 2 has all the similar signs and symptoms. However, it follows injury of a major peripheral nerve. As the pathophysiology of the CPRS type 1 is not well understood, the methods of treatment protocol are also vary. The consensus is that a multidisciplinary team treatment plan should be instituted. This includes PIPP, parapharmacological, interventional technique, physical modalities, and psychological interventions. When you talk about the pharmacological modalities, they can be antidepressants like TCAs or SSRIs, membrane stabilizers, anticonvulsants, local anesthesia, antiarrhythmic drugs, NSAIDs, topical medications like Imla and capsaicin or clonidine, as well as opioids. Regarding the interventional technique, it can be sympathetic blockage, ciliate ganglion block, lumbar sympathetic block, IV regional block, or spinal cord stimulator. The physical modalities look towards physical and occupational therapy, contrast baths, TENS, heat and cold massages. The psychological intervention include psychiatric evaluation, cognitive behavior therapy, relaxation training, imagery, and hypnosis. Now we talk about the pharmacological therapies in CPRS. The tricyclic antidepressants have been well studied in neuropathic pain. Tricyclic antidepressants like amitriptyline, nortriptyline, and desmipramine involve monoaminergic transmitter by blocking reuptake of serotonin and norepinephrine. The dose used for treatment of neuropathic pain is typically much less than antidepressant dose. The selective serotonin reuptake inhibitor like paroxetine and sertraline, although used anecdotally in chronic CPRS, have not been formally studied for this purpose. Regarding NSAIDs during complex regional pain syndrome, the main method is inhibition of cyclooxygenase. This leads to a reduction in the production of pain mediators and a reduction in inflammation. NSAIDs may be helpful in the early stages of CPRS. However, the potential of gastrointestinal complications and renal failure must be considered if continued use is recommended. Membrane stabilizing medications like local anesthesia, anticonvulsants, and antiarrhythmic agents are also in this category. Gabapentin, a selective voltage-gated calcium channel blocker, has shown some efficacy in managing pain in CPRS. Gabapentin has reduced side effects and an improved efficacy to toxicity ratio when compared with phenytoin and carbamazepine. Lidocaine has been used intravenously in the management of neuropathic pain. Intravenous lidocaine therapy is often followed by oral treatment with mexiletine. We talk about topical analgesic medications like local anesthesia cream like Amla have been tried recently in treatment of neuropathic pain in patients with CPRS type 1. Topical capsaicin used a reversible depletion in substance P and calcitonin gene-related peptide from the C fiber terminals. There are anecdotal reports of its use for localized hyperalgesias. Therefore, it can be tried for patients with CPRS with local area of pain. Patient need to formally be informed that initially its application may cause increased pain. This is secondary to the release of substance P. Talking about opioids in CPRS. Opioids are used in nociceptive pain, and their effect is related to interaction at the level of spinal cord with the opioid receptors. Although their use may be considered controversial in chronic non-malignant pain, a patient with unremitting pain should be tried on opioid therapy. This should occur early on in the treatment. It is important to control the pain. There are anecdotal reports of use of other medications for CPRS, like GABA inhibitors. Gamma-aminobutyric acid inhibitors such as baclofen has been reported to be used in neuropathic pain. Control studies of these use in CPRS have not yet been done. Clonidine has been shown to be useful when topically applied to the area of hyperalgesia. It acts by blocking release of catecholamines presynaptically. Clonidine has been administered epidurally and intrathecally in patients with CPRS. These patients are at much greater risk of hemodynamic complications when the drugs are used transdermally. Subcutaneous calcitonin has been used to be effective in treatment of spontaneous pain. Its use in CPRS has not yet been documented. In the early stage of CPRS, a patient may benefit from trial of corticosteroids. This is particularly useful for patients who present with edema or other signs of inflammation. Now we're talking about interventional therapy that can be regional blockage, IV regional blocks, or spinal cord stimulation. When we talk about the regional block, specifically sympathetic nerve blocks are used in both establishing the diagnosis and rather treating it. Patients with CPRS report relief of pain with sympathetic blocks, which is very useful in giving patient the analgesia that is required to participate in physical therapy regimes. If patients respond positively with the trial of sympathetic block, these blocks should be repeated as long as the patient continues to afford increased duration of pain relief and symptom improvement with subsequent blocks. In addition to assessing the level of pain relief reported by the patient should be assessed for signs of sympathetic block. The blockage may affect the nociceptor, visceral and somatic afferent and vasomotor, sudomotor and visceromotor fibers. One would therefore look for signs of increased blood flow to the limb involved, as continuous blood flow affects skin temperature, and this is controlled by the sympathetic nerve system, and increase in skin temperature should occur. This can be measured using surface temperature monitor or plethysmography. The limb should be examined for visual signs of increased vasculature. Blocking of sudomotor functions can be measured using ninhydrin, cobalt blue, or starch iodine. A quantitative sudomotor axon reflex test, QSART, can also be used. For CPRS affecting the upper limb, a styloid ganglion block is usually performed. Many patients develop Horner syndrome, that is, meiosis, anhidrosis, ptosis, and enophthalmos, after a styloid or a cervicothoracic ganglion block. Blockage of thoracic sympathetic chain is technically difficult, requiring radiological guidance, and is not commonly done. For the CPRS affecting the lower extremity, sympathetic blockage is done either by performing a lumbar sympathetic block or an epidural injection. It requires continuous block to be done. Regarding IV renal blocks, when we talk about the Bayer blocks, allow for prolonged exposure of the affected limb to the ganglion blocking agent. In the it is commonly used by beryllium. Beryllium accumulates in the adrenergic nerves and blocks norepinephrine release. These blocks can be used and performed with guanethidine and reserpine as well. When you talk about spinal cord stimulation, it's hypothesized to affect the pain based on the gate control theory, whereby stimulation of large myelinated fibers block pain transmission through the smaller pain fibers. Patients who either do not respond to regional blocks, medications, or physical therapy or are unable to pursue those treatments, options secondary to unacceptable side effects may be candidate for spinal cord stimulators. All patients must meet a strict criteria and have a successful trial of temporary lead. A trial is deemed successful if the patient reports decrease in pain and a reduction in medication requirement and improvement in function. So, you need to remember the spinal cord stimulation effects based on the gate control theory, whereby stimulation of large myelinated fibers block pain transmission through the small pain fibers. There are complications which can occur with all these. Early treatment and diagnosis of CPRS is essential for pain relief and restoration of function. The incidence of poor outcome is significantly higher in patients who present with CPRS greater than 12 months, in a second or third stage of the disease, and in case with coexisting nerve injuries, or compression or a consequence of initial trauma. Studies have shown a correlation between CPRS and psychological disorders, and this may complicate treatment.